Hi, my name is Annika Pilson, and I will be speaking today about diabetic foot ulcers and the role of the registered nurse. Here are the objectives. By the end of the class, students will be able to identify at least two risk factors for diabetic lower extremity wounds and indicate at least two potential treatment options based on the clinical manifestations of diabetic foot ulcers. Let's start with understanding what a diabetic foot ulcer is. It is an ulcer on the foot caused by a combination of poorly controlled blood sugars, neuropathy, repeated trauma and/or pressure, and peripheral artery disease. So how does this happen? Well, diabetes can lead to both neuropathy and a change in the structure of the foot. Neuropathy changes in sensation and also the amount of sweat that the body secretes. And the lack of sensation makes the patient unaware of any kind of repeated trauma. And so that could be something like stepping on a pebble over and over again. Or maybe their shoe is too tight and rubbing against the side of the foot, but the patient can't feel that. And also because they have decreased sweat secretion, their feet become really dry, which leads to cracks and fissures. And then calluses develop from repeating rubbing and the pressure, which is also related to that change in foot structure. So in diabetic patients, you have this thing called Charcot foot. And it's not really understood how it happens, but most often it does happen in patients with diabetes, which is why it's then associated with it. And what happens is that the foot has a restructuring and the bones maybe shift and sometimes fracture. And what happens is that there is a difference in the way that weight is distributed. So when the patient is walking on their foot in a different way, it eventually leads to an ulcer. So remember how I just mentioned that calluses form from the combination of changes due to the neuropathy? If it's left untreated, the patient continues to walk on the callus, which is repetition of trauma, and eventually that callus opens up. And then because of peripheral artery disease, the arteries are narrowed and they lack elasticity, and then that impedes blood flow. And because there's a decrease in blood flow, it affects the body's ability to heal the wound. So here is a picture of Charcot foot. And notice that the bones have moved. So you can see down here that now it's instead of having an arch that goes upwards, instead the foot is pointing downwards. And then over here is a picture of this. See this hard outside part here that's a little darker in color as well. That's the callus. And then inside here is how it opened up. And that happened because of the changing shape of the foot and then patient walking on it over and over again. So let's talk about clinical manifestations of the diabetic foot ulcer. What symptoms do you think the patient might present with? Well, they could have fever, chills, pain. But remember too, these patients don't have any kind of sensation on their foot. So if they have a a mild ulcer, they might not have any kind of symptoms at all. Then if we talk about a soft tissue infection, this patient is going to present with some erythema. It's going to be warm to the touch. They're going to have edema and maybe some pus there as well. And then osteomyelitis is an infection of the bone. And the gold standard for determining osteomyelitis is actually to do a bone biopsy, but that's done in the operating room. So another way to diagnose this is actually by having the presence of a visible bone, an ulcer that won't heal after over 2 weeks, an ulcer that's over 2 centimeters in size or bigger, and then also confirming it with radiography like an X-ray or an MRI. So once the diagnosis of a diabetic ulcer is made, we need to think about the treatment options that the advanced provider is going to prescribe. That includes antibiotics, debridement, wound care, and pressure reduction. And I'm going to talk more about these options on the following slides, but ultimately the goal of these treatments is to prevent amputation. And amputation could be something, where it's just a toe that's amputated. It could be part of a foot. It could also be a large portion of the lower extremity. And all of that is just depends on the patient. It's where the wound is located and any other comorbidities they might have, such as, the severity of their peripheral artery disease. So antibiotics are usually prescribed with an infection and only if they show signs of an infection. And oral antibiotics would be prescribed if the case is mild or it only involves soft tissue. But if the patient has a deep tissue infection or they do have osteomyelitis, which, as you remember, is that bone infection, they would need IV antibiotics. And then after that, it would be debridement. Debridement means cleaning out the wound, removing the dead tissue or the infected tissue. And that can be as easy as a doctor performing it at the bedside or more complex, like taking them back to the operating room. There's also topical ointments that can be prescribed to debride. Um, and then you can think about biological methods to debride, such as maggots. And maggots can actually be really helpful because you put them onto the skin, they only eat the necrotic or the dead tissue. You cover them up with a certain kind of dressing, and some maggots can actually secrete antimicrobial substances that can help with some sorts of infections. So again, continuing on with our treatment options, with wound care, these patients are going to need some kind of a dressing, and we always want a clean and moist environment to help promote healing. We do this through wet to dry dressings, and the dressings can be just with saline, but they can also be with some of those enzymatic ointments that I had mentioned on the previous slides that help with debridement, because they can also help with promotion of healthy tissue growth. And then there's also negative pressure wound therapy, which is also, you might have heard the term of wound vacs before. That's what I'm talking about there. And then pressure reduction means taking the pressure off of that ulcer. So ways to do that are with custom made or maybe not custom made shoe options. A post-op shoe is often used immediately because it has a wider base and you close it with a Velcro strap, so it can accommodate a bulky dressing, a wound dressing, and also can just kind of help basically redistribute weight. But something that is more specific for the patient would be orthotics or rocker-soled shoes or removable cast walkers, which I'll show you on the next slide. So here's a rocker-soled shoe here on the left, and you can see it kind of takes some pressure off both the front and the back. I think they kind of look like Hokas myself. And then here is a removable cast walker, which is more complex and it's more bulky as well. And the interesting thing about both of these options is that although they're great for removing some of the pressure from the ulcers themselves, the patients actually report that they are not as active as they used to be because of the difficulties of walking in these options. And sometimes it can really throw off balance too. So the concern about using these with some patients is, are they already a fall risk? And now we're making that a bigger problem. So what is the role of the registered nurse? Well, we're going to provide that wound care and we will administer antibiotics. But what we really need to do is promote resilience and independence. And we do that by educating the patient and the family. Right? We want to involve them in that wound care and we want to involve them in the antibiotic administration. The more education we can provide, the more that they know and the more independent that they will be. So what is that education that we need to provide to our patients and their families? Well, we need them to maintain their blood sugar control. Now that level is determined with, the patient determines that with their endocrinologist or their primary care doctor. And we really want to try to keep them in that range. And it can be harder because when you have an infection, your blood sugar will go higher. And then we want patients to quit smoking if they still smoke. It is a big risk for peripheral artery disease, and it can prevent healing of that ulcer. And then we want to talk to them about their nerve changes, right? They have a lack of sensation, so they need to be vigilant about the appearance of their feet. That includes daily foot exams as well as the annual exams with their provider. And what they're looking for is any cracked skin, calluses, ulcers, or changes in the shape of their feet. Remember that change of the foot structure itself can lead to the development of breakdown. And proper foot care includes cutting nails straight across, using lotion if they have dry or cracked skin, trying to prevent skin from opening up, making sure that they always wear shoes when they are walking, because remember, they're not going to feel if they step on something. Right? And they also need to examine their shoes to make sure that they aren't too tight and that there isn't anything inside them. And as for the impaired circulation, can they feel their pulse? Are their feet and toes warm or cold? What color are their feet compared to the rest of their leg? And are their feet swollen? Changes in foot findings need to be communicated to their provider. And it's our responsibility as nurses to educate the patients on this information. And that is all for the basics of diabetic foot ulcers. Thank you so much for watching and listening. I hope you found this information helpful. Here are the references that were used in the creation of the presentation.